you get into the meeting, but we can rename you and make sure that everybody gets credit for attending the session. Still got about a minute till noon. Okay, I think Erin is currently muted. Hopefully you can hear me. This is Andrea talking.
I wasn't talking, but I can talk.
We do love to hear your voice, Erin.
You might also hear my daughter's voice crying in the background. Hopefully she'll stop, but not my responsibility right now. We got lots of family here today.
Here you go. I know Erin is traveling and is still joining us for the webinar. That's dedication, which is all of you. We weren't sure, since I know that a lot of schools are off today and such, what our attendance was going to be, but it's great to see so many of you joining today. I'll say it again, those of you who have been on for a while, I apologize. I'm going to keep repeating it, to put your name in the chat so that we can make sure that we see that you're there and we're able to give you continuing education credit. Hi, Janae, it's good to see you. And just your name and your role is also always appreciated, just so where you work, just so everybody knows we've got a fabulous, really awesome interdisciplinary attendance in our groups. And I love for you all to see who are there. Those of you who were on last time, sometimes I put a question out to the masses, because you all know a lot more about your area than I do. So it is fabulous to see you. Keep putting those names on. We are at noon. So with that, oh, Katara, it's good to see you too. Great to see familiar and new faces. Well, welcome to our second session of Bridging Mental Health and Intellectual and Developmental Disabilities. Today, we're going to talk about intellectual disability and autism spectrum disorder, and really how they intersect with mental health and those considerations. We have two awesome speakers here from the OSU Niswonger Center. We have Erin Harris, who is an independently licensed social worker at the OSU Niswonger Center. She's a clinical social work manager for the Autism College Experience program and serves as social work faculty for our Leadership Education and Neurodevelopmental Disabilities, or LEND program, which is an advanced graduate interdisciplinary training program. She also teaches as a community lecturer for the OSU College of Social Work. Prior to Niswonger Center, she was a behavioral health therapist at Nationwide Children's. And in her free time, which I'm not sure how she has any, you can find her raising her, she and her husband raising their daughter and working on their small farm. We also have Dr. Emily Carey, who is a psychology postdoctoral fellow at Niswonger Center. She completed her PhD in psychology at Syracuse University and a predoctoral internship at the UNC Chapel Hill Teach Center. Her clinical and research interests include sensory processing and autism, mindfulness-based interventions, and the assessment and treatment of autism and developmental disabilities. With that, I'm going to turn it over to Erin and Emily so that they can start talking to you. Just a reminder, at the end, I will show a QR code to complete the survey. And for continuing education credit, it is our expectation that you stick with us till the end, which you're going to want to do because these ladies are awesome. Feel free to put questions in the chat. We will likely hold most of them until the end, unless Emily and Erin feel so moved to respond to them.
Thank you, Dr. Whitwer. All right, so we're going to get started. We have a lot to share with you today. So like Dr. Whitwer said, feel free to post your questions in the chat. We may or may not get to them during our conversation today, but we definitely can get all of those questions answered at a later date. Emily and I's goal for the day is to help you guys learn a little bit about intellectual and developmental disability and also autism. So we're going to talk a little bit about signs, symptoms, diagnosis, as well as just what are the major challenges with that adults with ID and DD face. So we're going to get started, and I'm going to skip through some of these slides. These slides will be available later on, so you can read up on our mission at the Niswonger Center, a little bit about the Building Bridges project that is the reason we are here today, sharing this webinar. And then our next webinar is going to be on May 5th. Here's our agenda for the day. And then I'm just gonna let Emily take over and get started.
All right, so as Erin said, I'm going to go ahead and start with more of the diagnostic pieces of what we think about around developmental disabilities, and then we'll go into services and some considerations after that. Developmental disabilities are kind of like a broad definition from the CDC, the Center for Disease Control and Prevention, is that developmental disabilities are a group of conditions that are due to an impairment in either physical, learning, language, or behavioral areas. These conditions begin during the developmental period, and typically we would see them early in development, often before entering elementary school, but development at the neural level can occur up to the age of 22, so we have a more flexible definition of that as well. Typically, these conditions last throughout a person's lifetime, so we think of them as being ongoing and may impact day-to-day functioning. So some areas that might be impacted include self-care, receptive and expressive language, learning, mobility, self-direction, economic self-sufficiency, and capacity for independent living. And then going into the next slide, developmental disabilities, again, are more of a broad term that can encompass a range of different disabilities. So that includes global developmental delay, which is when younger individuals are not meeting developmental milestones in different areas of intellectual functioning. And this is often prior to an age where an intellectual disability diagnosis would be given. Other disabilities include intellectual disability, autism, language disorders, physical disabilities, developmental delay, genetic syndromes, fetal alcohol syndrome, as well as a variety of others. Clinicians often use the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, to diagnose a range of mental health and intellectual and developmental disabilities. Within the DSM-5, the category that we tend to look at that's most comparable to developmental disabilities is neurodevelopmental disorders. And that includes intellectual disability, communication disorders, autism, ADHD, specific learning disorders, motor disorders, and then there's another category. And so for this talk, we're going to focus specifically on intellectual disabilities and autism and dive more into the specific diagnostic criteria of those two. So starting with intellectual disability, there are multiple previous terms for what was previously used to refer to as intellectual disability, such as mental retardation, that's now considered outdated and offensive. So just wanted to point out that intellectual disability is certainly the term that we want to currently use. And it's one of those things that can be really nice if you observe other people using outdated terms to kindly point out that individuals with intellectual disability prefer that term, and to try to increase the use of that term as well. Going into the next slide, going back to the DSM-5, the way that we diagnose intellectual disability is through 3 different criteria. So the first criteria is deficits in intellectual functioning. And so that typically includes things like reasoning, ability to problem solve, to plan, to have abstract thinking, using judgment, academic learning, as well as learning from experience more broadly, practical understanding, and these areas are confirmed both by clinical assessment as well as individualized standardized intelligence testing. So for example, one commonly used assessment is the WAIS, the Wechsler Adult Intelligence Scale. And typically we want to use tools that are measured and administered that are like psychometrically valid, comprehensive, and culturally appropriate to the individuals that we're assessing. And then we typically will look at 2 standard deviations or more below the population mean. So a score of about 70 or below for the diagnosis of intellectual disability on standard IQ assessments. Going into the second area, that area is adaptive functioning and includes 3 areas: conceptual, social, and practical. So conceptual adaptive functioning are things like communication, academic skills, being able to self-direct one's ability to initiate tasks. Social area of adaptive functioning includes leisure and social activities. And then the practical area of adaptive functioning includes using the community, going to the library, home living, being safe in one's home, caring for oneself as an individual, able to prepare food for themselves, brush their teeth, etc. And so this criteria is met when at least one of those 3 domains of adaptive functioning is sufficiently impaired that ongoing support is needed within that domain. And again, we assess these using both clinical evaluation as well as individualized, culturally appropriate, psychometrically sound measures. And then going into we'll actually fast forward past this slide and into the next one. Adaptive functioning will often recruit additional sources of information to assess this. So we often will look at educational records, developmental records, medical records, as well as any previous mental health evaluations that have been completed. And scores from standardized measures and interview sources will always have to be interpreted with clinical judgment. So we're not just using scores, but we're always using clinical judgment beyond the measurement tools that we're using. So I've got a few, I'm going to go through one more criteria for intellectual disability. So the last criteria is onset of both the intellectual and adaptive deficits during that developmental period. And again, typically that's going to be early on prior to school age, but it can be any time before the age of 22. So this can be present during childhood and adolescence. All right. So just wanted to kind of ask a few questions to kind of gauge your understanding of intellectual disability and what you know so far. So if you can just put in the chat what you think the response to this question is, what is the prevalence of intellectual disability? So how many people do you think have an intellectual disability? And you can just go ahead and put the letter response of what you're thinking. All right, so we've got some guesses around 5 to 7%. A lot of people are guessing like 6 or 7%. Some people 4%. All right, very nice. Thanks so much for all of your responding. So the response to this question is actually that the prevalence of intellectual disability is around 1%. Some of the more recent estimates have been closer to 2 to 3%. So it does seem like we're identifying more individuals with intellectual disability, but certainly less than what all of you have anticipated. And perhaps it's that you all are kind of working more with this population, and so you're seeing it more than others might be. So the next question I have for you, going to the next slide, is what is the percentage of people with mild intellectual disability? And so these are going to be individuals that have some adaptive impairments, but not to a severe degree. So some difficulties in academic skills, some immaturity in social interactions, but not to a significantly impairing degree. So a lot of people are guessing quite a range of responses. So 25% is pretty, I'm seeing a lot, 25 to 50% is kind of the more frequent response that I'm seeing. So we'll go into the response for this one. About 85% of individuals with intellectual disability have mild intellectual disability as compared to moderate, severe, and profound intellectual disability. And to kind of have a sense of that, profound intellectual disability is at the other end of the scale and really would mark very limited communication, reliance on others for physical care, reliance on others for safety and health. So a lot of these individuals really are going to be more on that mild spectrum. All right, going into the next question. What is the potential grade level that people with intellectual disability can achieve in terms of reading and writing? So that the response options are from illiterate, which is response A, to 10th grade. Okay, so seeing a range of like 1st to 6th grade in your responses. Some people 10th grade. Excellent. Thanks again all for responding. So going into the response for that, typically the potential grade level that a person with ID will achieve tends to be around the 6th grade level. So when we're writing materials for these individuals, typically we'll cater to around that 6th grade level. And so that can be helpful, kind of thinking about how we can cater our language. And Erin might go into that a little bit later. Going into the next slide. What % of students with intellectual disability leave high school with a regular diploma? And the range of options are from 0 to 37%. Being around 19 to 37% right now. Okay, so a lot of guesses on that higher end. Excellent. Yep, again, 19 to 37%. All right, so we'll go into the response for this one. About 37%, so you all were pretty close on with this one, of students with intellectual disability do leave high school with a regular diploma at the end of that, of high school. And you can see here in this graph that that's been pretty consistent within the past years, that's about the percentage of students. All right, so we'll go into the next slide. Really important thing to kind of emphasize is that you really cannot tell if someone has an intellectual disability just by looking at them. And you can't tell if someone has an intellectual disability just from talking with someone. It really does take a rigorous individualized assessment of the person's functioning through intellectual functioning and then also observing adaptive behavior. There's a lot of common misconceptions regarding people with intellectual disability. So some of the misconceptions that I've heard is that they don't know right from wrong, so that morality piece, they can't learn, they can't read, that they have a flat IQ or adaptive profile, meaning that it's kind of like consistently low across the board, but really we do tend to see variability in strengths and challenges. We sometimes will hear that people think that they can't use a bank account or can't use a credit card, that they can't learn or have a driver's license, that they can't hold or find a basic job. And more, we're also hearing that a lot of people don't think that people with intellectual disability can also have any kind of co-occurring mental health conditions. And these are all misconceptions that certainly are not accurate. There is a lot of variability in skills when it comes to individuals with intellectual disability, and a lot of different things that they can do with their careers and futures and with having a family, depending on their values and interests. So we'll go into the next slide. I'm going to talk now about autism spectrum disorder and go into some of the diagnostic criteria for autism. So again, based on the DSM-5, the way that we diagnose autism is within two areas. We look at social interaction and communication, and then the second area is restricted and repetitive behaviors. When diagnosing autism, within that first category of social interactions, an individual has to have all three deficits in interactions, and I'll go through each one. So the first is deficits in social emotional reciprocity. And oftentimes I think of this as like kind of tossing a ball back and forth. So if I start the conversation and I say, last week I went to Florida and I had a great trip, I'm passing the ball to the next person and I'm going to see how do they respond. Will they ask me how my vacation was? Will they talk about their interests in travel and then kind of go on a tangent about that? Or will they just drop the ball and not respond? And so kind of thinking about how are they interacting, that back and forth conversation that we might expect. The second area is deficits in nonverbal communication. So things like gestures, are they using gestures, eye contact, facial expressions, things like that to modulate the conversation. And then the third area is deficits in relationships. And this is really about their ability to initiate and sustain friendships over time. So again, they need to meet all three criteria, deficits in all three areas. And then the second domain that we're looking at is restricted and repetitive behaviors. And with this one, they need to meet two of these four criteria for the diagnosis of autism. The first one is repetitive movements, use of objects or speech. So we might see a history of hand flapping, body rocking, spinning, any kind of repetitive motor movement might fall within that category. And then also repetitive speech. So things like echolalia, for example, when they're repeating exactly what they hear and often in the same kind of inflection and tone. The second one is inflexibility in rituals. We often see individuals with autism have a very rigid routine, and any variability from that routine can cause stress. Or sometimes if it's an individual who can't speak, we might see more behaviors when there's changes in routine. And then difficulties with transitions can also be common in that area. The third one is restricted interests. So individuals with autism might have specific restricted interests where they can spend hours focused on one thing. They might collect that item. They might talk about that item or topic for hours. And it's hard to be flexible to other topics of conversation. And then the fourth one is sensory hyper or hyporeactivity. So being unduly sensitive to certain sensory aspects of the environment, such as tactile textures or sounds, or being very interested in certain sensory aspects of the environment. So for example, really liking weighted blankets or certain sensory textures to a point where they're kind of engaging with that texture for quite a long period of time, or in different environments. And then similar to intellectual disability, we're looking for onset within the developmental period, early developmental period. And so typically we're going to do both an interview to assess for early developmental traits of autism, as well as doing a in-person observation, typically through the ADOS, the Autism Diagnostic Observation Schedule, to directly observe current behaviors. When it comes to identifying individuals with autism, I know a lot of you work with adults. Kind of early on, pediatricians are going to be the first screeners who are doing developmental screenings at typically 9, 18, and 24 months, with 2 of those time points being more specific to autism symptoms. And then children will also undergo comprehensive developmental assessments, including autism symptoms, learning, and communication. But kind of thinking about older individuals, a lot of these younger kids will slip through the cracks, depending on their pediatrician and their access to services, as well as different disparities. So a lot of the time, females are or underdiagnosed, depends on economic status and rurality. So those factors might lead an individual to get diagnosed later in life as well, based on lack of referral. Other potential referral sources include school professionals, counselors, psychiatrists, therapists, and parents. And that can be important, especially as we see individuals get older and potentially have less eyes on them over time. And then briefly talking about services, when kind of thinking about intellectual and developmental disabilities between the ages of 5 and 22, some common services that are provided are through the County Board of DD, which typically provide assessment and service planning, as well as coordination of services. Another option is SSI, Supplemental Security Income, which provides monthly payments to individuals, especially for those below a certain income. Individualized education programs provide services within the context of school. Mental health is another kind of domain that provides services from psychologists, psychiatrists, and counselors. And then speech, occupational, and physical therapy are often common services as well. Beyond the age of 14, we also typically will recommend opportunities for Ohioans with disabilities, OOD, to help with employment and disability determination for Social Security benefits, as well as transition planning, typically in high school as part of one's IEP, to help plan for after high school, provide assessments to determine skills and interests, as well as starting to think about independent living, depending on the needs of the individual. So with that, I will now kind of pass this over to Erin to talk about considerations in communication with developmental disability.
Thank you, Emily. I'm actually going to address a question that we have. So one of our questions is, I've been hearing the term neurodivergent more and more in conversation and a way people seem to identify themselves. Can you discuss how all of that aligns with spectrum disorders? So that actually fits very nicely with my first slide here. So in talking about the language that we use when we are, one, as professionals or providers or whatever, addressing someone with an intellectual or developmental disability, or someone who is neurodivergent, really is going to be very individualized. So when we talk about person first language, we're using the person as the identifier rather than the disability. So it would be an individual with autism or a client with depression. The goal here is really to reduce that stigma, stereotyping, prejudice towards people with disabilities, and counter any negative or ambivalent attitudes towards people with disability, and really shifting that just the person is the person rather than the disability. Then on the other side, we have identity first, which would be autistic individuals. The goal here in people who use identity first language is that they feel that that they would not be themselves without their disability. So they are one and the same thing. How does neurodivergent fit into this? So neurodivergent is a term used basically for those who have a variation in their neurology. Lots of different things can be considered neurodivergent. So labeled disabilities such as autism, intellectual disability, ADHD, anxiety, depression, Tourette's, lots of different things like that would be considered neurodivergent. In terms of how people are using this term, I think there's a big spectrum here. So you may self-identify as neurodivergent without any kind of clinical diagnoses. Or you may have lots of clinical, documentation and background that would be able to describe that neurodivergence that you have. I think more and more, specifically in the clinic that Emily and I work in, if someone is coming in for an autism diagnosis and they don't meet criteria for autism, we provide some information about the neurodivergent community. So just because they don't get that autism diagnosis, that doesn't mean that they wouldn't fit in with the neurodivergent community in terms of how their brain is working and functioning. So I hope that answers the question. And if not, feel free to put some follow-up questions, and I'm going to move on. So I think I mentioned this already. So how do you know what to use? I like to tell people really just ask. Think about it as how it's more and more common to ask what pronouns people use. It's very okay to just say, hey, how do you identify? Do you like to say a person with autism or an autistic person? And what you might find is that some people really care and they want to use person first. Some people really want to use identity first. And then there's a group of people that just don't care. And so here are just some quotes that you guys can read for some different folks who identify in these different ways. Okay. All right, so Emily kind of talked about what are some of the communication challenges. These are both with autism and intellectual disability, so any developmental disability. Things to think about when you're communicating is there may be some difficulties with our expressive language, so saying the things we need, we want, asking for help, requesting a break. You might, so with ASD, you might have someone with echolalia repeat what others are saying. And then we have the opposite, which is the receptive language. So difficulty understanding what people are saying to you. Processing can be slower. There might be words or vocabulary that isn't understanding. So when you are communicating, just some simple tips to think about. So using very clear language, breaking sentences down, not asking 5 questions in one question, speak at a slower pace. And I think this is tricky because I don't mean talk really slow. More so pause between your sentences. So say a sentence, pause, look to see if there's some understanding, ask clarifying questions. Did they understand me? Things like that. I'm not suggesting to use anything like baby talk or speaking to someone like they're a child. You really can just kind of slow down your pace. Think about how can I clearly communicate this information. A lot of times using visuals can be helpful, as well as gestures. I told everybody I wasn't going to talk with my hands today, and now I am. So thinking about how do you use gestures, how can those be helpful? And then, so these are kind of things you can do as the individual, but then there are other things that you need to kind of think about when talking to these people, when talking to people with an intellectual or developmental disability, thinking about their nonverbal. So they may not be someone who looks you in the eyes. They may not be someone who nods or shakes their head no. A lot of times that might seem like they aren't listening to you. So it's important for you to be aware that doesn't necessarily mean we're not listening. Again, asking questions. Does that make sense? Did you hear what I said? Do you think you could summarize what I said or tell me back what I said? Having some interactions that way. Very common for folks to not pick up or understand sarcasm or subtle jokes. I am someone who uses sarcasm very regularly and have had to get very good at kind of labeling my sarcasm. So, hey, that was sarcasm, or saying, hey, did you catch that joke? Kind of things like that when I'm talking to folks with communication differences. Also thinking about social withdrawal. I think this is a big one when we're thinking about diagnostic information of mental health. So just because someone is not really interested or prefers, some social isolation does not mean that they are depressed, does not mean that they're going through other things. That might just be their preference, and that's okay. So that's something that's really important to think about, when you are doing assessments, when you're in active treatment of some kind. Hey, is this different than normal for this person? Or are they always kind of someone who isn't really interested in social interactions? I think I already mentioned eye contact, so we will move on. Okay, we're going to talk a little bit about trauma. I'm not going to dig a ton into trauma because we will have another webinar in the future solely focused on trauma. But my big takeaway for you all today is that folks with developmental disability, any kind of disability, are significantly more at risk as children to be physically abused or sexually abused, more than twice as likely. Why is this important? We're talking mostly about adults today. Well, children become adults and trauma doesn't usually fix itself overnight. So a lot of the folks who are adults may still have some difficulty with the trauma they experienced as a child. All right, some more facts for you here. Again, big takeaway. 70% of people with disability reported they've been victims of abuse. Around 41 of them were some type of sexual abuse, 34 being victimized multiple times. So for someone who has experienced abuse, more than I would say around half or more than half have experienced it more than one time. So this is kind of reoccurring trauma for a lot of these folks. Again, some more stats. And so I will note these are a little bit older stats, but this is still a pretty prevalent situation. It has not magically disappeared in the last 10 years, so just something to think about. All right, so what do you do? Again, briefly diving into this, trauma treatment is a pretty in-depth process. So unless you are, an expert in trauma, I would not suggest that you go do some trauma work with someone with an intellectual or developmental disability off the bat. But some things as a clinician or a provider or an SSA, or even just somebody on, out in the community, it's real important to establish that positive relationship. For some of our folks, it takes a little bit more to get there. Rapport building might take a little bit longer than what you're used to. It's helpful to identify the circumstances that might be upsetting the individual and just be a warm and accepting, calm, reassuring person. So basically, be a good human. I think, you know, it can be scary to approach somebody who's going through some kind of trauma, but most of the time, if you are calm yourself and warm and accepting, that helps them respond in a similar manner. All right. So emotional and behavioral problems. So if we think of co-occurring mental health, studies have found that 50% of individuals with DD experience some kind of emotional behavioral problems, and then also that co-occurring psychiatric disorder. 70% of children with ASD typically meet criteria for one additional co-occurring psychiatric disorder. So things to think about, and I think this is getting ahead. My next slide is going to talk about diagnostic overshadowing, but some questions to think about, again, if you're referring someone for an evaluation, if you're thinking, man, these behavior difficulties are out of control, we're not sure what to do, just some really good questions to think about. Is there a medical cause? Figuring out what is the function of the behavior. So why is this happening? Is there something, really simple that is causing this? So a change in weather. They no longer get the type of cereal that they get every morning, and they're having a hard time adjusting to that. So thinking about, is there kind of a common sense reason for the behavior you're seeing? Now, what happens oftentimes is we have diagnostic overshadowing where folks aren't getting a diagnosis, a co-occurring diagnosis. They mean like anxiety, like depression, like ADHD, because what happens is they're kind of all just overshadowed by, well, this person has a developmental disability, so that's probably just what that is. When really what we're finding is we're missing a lot of this anxiety, depression, diagnoses that are coming with a developmental disability. So just something to kind of think about next time, you experience a confusing emotion or behavior or something in a person that you're working with is, is there something else going on? I kind of already talked about this. I think that, again, big takeaway, functional behavioral assessment is really helpful in planning when you're dealing with problem behaviors. I don't even like the term problem behaviors that much, because a lot of times it's really a simple, like a miscommunication situation, or we're not communicating in a way that other people are understanding. And so if we really just figure out what is going on, like, why are we doing these things, you're going to find out it's because they are trying to communicate something else that they're not able to in a way that we understand. Other stuff to think about, really gathering as much information as you can about the person you're working with is going to help you. It's going to help you understand and advocate all of the things you need. I have whole child, but really adult too. I mean, knowing all of the information you can gather is going to be able to help you understand what is the needs. Not an easy proposition, but something to strive for. All right, I'm going to get into a little bit more exciting than just me talking. And we are going to watch some videos of some folks with lived experience. So we have Patrick here. Patrick has autism, and then we're going to talk about another individual named Christine who has an intellectual disability. And then we're going to have plenty of time for questions. Right. Hello, thank you for taking the time to share about your experiences related to autism. The topic of our our webinar attendees are learning about are intellectual and developmental disabilities, including autism. So
Mhm.
we would like to hear a little bit from you about the people in your life that have supported you and give you a chance to tell others how they think that how you think they can support adults with intellectual and developmental disabilities, and any other co-occurring mental health conditions. So first, you want to tell a little bit about yourself, who you are. So tell us who you are and what you do.
My name is Patrick Meehan. I'm currently on the autism spectrum. I don't consider myself disabled. I consider myself neurodivergent because neurodivergence is inclusive. Disabled is stigmatizing. I kind of have the same attitude as my friend Brianna Miller, who is very smart, and she's also inspired me to create my own words because she does it too. Also, I've been very lucky to have good support. My family's been supportive. My parents, Tom Fish has been valuable support. Ashley Hillier was, of course. Jeff Siegel supported me. Pat Klopper. I don't know if you know Pat. She's my friend Brian Klopper's mother. She's kind of supported me a little bit. People through Franklin County Board DD have been supportive. A lot of people, and even friends who I know who I have personal relationships with at work who've been very supportive. And also just different people and aspirations who folks who are not as socially divergent. That's a term I came up with, but who are more socially typical. And who kind of helped me be more socially typical over time. Just practicing getting out there and also really trying to push myself to get out there and meet people, not just aspirations, but in general.
Right.
As there are many different groups like with Meetup that are very helpful and supportive of all people from all walks of life.
Yeah, so Patrick, you shared people that are supportive, but also it sounds like activities or things that you do that help support you. I think that's great. Is there anything specific that some of the people that support you, anything specific that they do that you find helpful?
Well, provide me moral support, like, when I'm struggling to communicate, or sometimes I have echolalia tendencies. I tend to repeat questions over and over again, can get a little bit annoying. People who are patient with me, who don't yell at me, who are very supportive. My mother's not always the most patient. She tends to yell at me a lot because she gets tired of me bugging her with the same questions. So I just got to be aware of that and know that, okay, I asked this once. It may not have come out the way I expected it to, but that's the answer they gave me. Don't keep beating it to death.
That's great. Okay, so being patient, helping you kind of work through that communication. Is there anything, I guess, I'm going to ask you kind of the opposite question. Is there anything that people have done to try to support you that did not go well?
Well, when I first got out of high school, I went to a psychologist who wasn't very familiar with autism. I only saw him a couple of years. I mean, he tried to help, but it wasn't very supportive. Could have done better. I did go to a psychologist in 2006 named Dr. Keith Hughes. He's been very supportive of me. He's helped me get to where I am today, like psychologically.
That's great.
But I haven't seen him in a while because he's having deteriorating health issues. So I'm trying to find another psychologist. Not for long though, because Dr. Hughes said that I didn't really need to see him that often, only once a month, because I was doing so well.
Yeah, that's awesome. Okay. Now my next question is, do you mind sharing a little bit about some of the things that you have challenges with or things that you're kind of working to improve?
Mostly in my mood, I tend to sometimes lambaste people, not out of meaning, but with my language delays. I've gotten speech therapy to deal with mixed receptive expressive language barriers, which cause me to not express myself. And possibly lambast. I've been known to do that before. I've done it to a couple people from aspirations way back in the 2000s. You know, I have an ego problem too.
Okay, so that's something that you're also working on. All right,
Yes.
good to know.
And just not getting my way. You know, it's important to not for nobody to get their way all the time, because that's not how life works, you know.
Okay. And so those things that you mentioned that you're working on, do you feel like you've made progress over the years?
I have, yes. I just have to keep thinking positively. I'm part of a whole bunch of Facebook groups on autism that's been very supportive as well. I'm also part of an autism positivity group on Facebook.
Good. Okay,
And
so that's another thing that you've mentioned that's helpful in supporting you.
Facebook,
So
yes.
Facebook, that's great.
And posting things that from the autism groups to my friends to see they like it, you know. I'm friends with a bunch of people from aspirations on Facebook. You know, I'm not going to say their name for confidentiality purposes, but you know who they are.
Yes, good job.
And I'm also friends with, I guess I can mention Tracy and Vicky, because they're facilitators.
Yeah, that's great. All right, Patrick, is there anything else that you would want people supporting people with autism to know?
Well, for one thing, don't put us in boxes. We're not collective. We are individuals. If you treat us with the respect we deserve, understand that, you know, that with everybody there's equity. You know, like equality is where everybody does the same thing. Equity is where you make exceptions and provide accommodations. If we focus on the three things in life, diversity, equity, and inclusion, things would be a lot better, I guarantee you. And I must admit, you know, took a lot of courage to do this, a little nervous, but you know, I did well. I know I did.
Yes, you did. You did great.
All right, thank you.
Right, so that was Patrick. Now we're going to hear from Christine. So pause. Hello, thank you. So Christine wanted to potentially be in person for this when I interviewed her, but unfortunately we were not able to. So there are a few glitches in our recording, but I think you'll still get some really good points across from it. All right, welcome Christine. Thank you for joining me. So we're gonna get started by if you could share a little bit about yourself, who you are, what you do, and anything else you'd like to share.
My name's Christine Brown. I am a person with an intellectual disability. Also am a clinical research assistant at the OSU Niswonger Center and the Self-Advocate faculty. I found out about my intellectual disability when I was about 17.
Okay, so you were 17. Who would you say, or could you tell us a little bit about who supported you then and now, and what has been helpful?
Yeah, the parents supported me, and we fought for services because they didn't think I qualified at first for DD services, but then when we spoke and showed evidence, it got approved.
Wonderful. All right. So currently now, who are the supportive people in your life, whether it's family, relatives, or providers, coworkers? Tell us a little bit about that.
Well, people who are in my life, my parents still support me even though they're retired and don't live in town anymore. But I have Jean Stunts, who I've known for 20 years. This year, she feels like a second mom, even though she isn't. And then I have Jeff Davis. he and I have known each other and was my mentor in teaching me to go speak to legislators. He's so caring and checks in, which is what we like to have people do, because that gives, so whenever we retire, the touch with you, you feel like they're still connecting with you.
That's great. So Christine, what if there was any like one thing or a couple things would you share with people in a supportive role, that something that they can do to be supportive?
Try to help the person whenever they are going through any kind of emotional trauma, because it is something that about 60% of people with intellectual and developmental disabilities deal with, and it's twice as worse for people with intellectual and developmental disabilities on their impact versus somebody that doesn't have an intellectual or developmental disability.
Great, thank you. And then any final words, anything else that you would want to share with people about yourself, or ways that they can help and be supportive, or even the opposite, anything that they shouldn't do?
Well, they shouldn't try to let the system be in control of what they should be able and not able to get. Because the thing is, I've always said this over and over, we're the asset of the system. If individuals or families didn't exist, then this job economy wouldn't exist. So our voice matters because we're the expert, because we live it every day.
That's great. I think that's been a theme of all the people that I've interviewed, is listening to the person with lived experience and hearing what they have to say. So I appreciate that you shared that. All right. Thank you very much, Christine. And that's all we have. So I think this will be wonderful to share with people, and that's all. All right. Okay. Now, both Christine and Patrick were wonderful to interview, by the way. I have known both of them for quite a long time, and they were champs and hanging in there with me. So any questions? So we've talked about diagnostic criteria. We've talked about kind of what does that actually look like in the real life. Talked a little bit about trauma, communication. What questions do you guys have for us? You can put them in the chat. I think we can unmute you if you wanted to just speak your question.
Yes.
If you don't,
If anyone
go for
wants to raise their hand, they can raise their hand. I'm happy to unmute you. You can type in the chat, do a combination of both.
Janae, I see that you raised your hand. If you want to go ahead and unmute, if you're able to do that, you can ask your question.
Can you hear me?
Yes.
Yes.
Okay, I have a question. I don't know if it's right to ask this in this setting or not, but when you look at diagnostics, are you all starting to see more and more individuals that have autism or ID that will be considered a sensory disability, like, for example, blindness? And I'm only mentioning, I'll give you an example. My mom works at a elementary school here in the city, and there's a student in the school. He's a first grader. He's autistic, but he's also blind. Are you all seeing that? Do you all have any studies of that? Is that coming up, not just here in Ohio, but across the country, where people are having multiple diagnoses? Just wondering.
Janae, thank you. I can speak for myself. So I am only in a very small clinic that I see transition age individuals. I have not come across anybody with any kind of visual impairment, more than, reading glasses or something like that. But we have had a couple of folks with some hearing impairments that we've worked with. I don't know, it looks like Dr. Whitwer, you hopped on. Were you going to maybe provide some insight there?
Yeah, I can talk a little bit. And maybe Emily can also nod or chime in as well. Janae, I don't know that there's any research thus far on the co-occurrence with those types of sensory disabilities, but I, like Erin, can talk a little bit about what I've seen and experiences and kind of understand. I think there's definitely been a trend as of late for, I know here locally, our School for the Blind, to really understand that they do have groups of children that do have this co-occurrence and trying to work towards managing that, referring them to us to get diagnostics, and us trying to think about how to do that for folks thinking about their sensory difficulties. I think just like with a lot of other folks, if we think about girls and females and women and other groups, I think people are realizing that you can have autism in addition to a sensory difficulty or a physical disability or some of these other aspects. And I think that's helping us understand them. I'm not sure nationally what the trends is. That's something we can definitely look into and report back though.
Okay, I just wondered, because I remember being, now that I know what I know now about autism and ID, looking back at people I went to school with who are blind, when you think about those typical things you don't know that aren't quite noticeable, but when you think back, you see some of those signs and symptoms. There are classmates of mine that probably had some neurodevelopmental issues, but weren't identified because for probably what was seen was that they were blind, and that was the primary focus.
Right. It's like they were talking about diagnostic overshadowing. It's kind of the same thing. People were just focused on that one sensory impairment and not the other. I also saw Erin and Emily a question in the chat. Why is it so difficult to link children to counseling and psychological services? We learn what they need, but there are not enough services to help children. I agree. I think that is a nationwide challenge, which is why our larger building bridge, I'll let you guys chime in too, but I'm going to take this selfish moment to plug our project. So Bridging Mental Health is part of a larger grant that NYSUNGR has to really increase the capacity of the mental health and DD workforces to meet the needs of children with disabilities, adults with disabilities. And so that's really the goal. There's a definite recognition that we need to provide more training and really work on increasing even those preparatory training programs to equip folks to meet those needs when they come out of school. But it's frustrating, and that's our goal, is to really try to increase the training, both first in Ohio and then nationally, so that we can increase that capacity. We share your frustration.
Yeah, I think, going back to that diagnostic foreshadowing, I think a lot of clinicians, therapists are worried, well, I don't know how to treat autism and I don't know how to treat intellectual disability. But the majority of the time, those folks are coming to clinicians, it's really to treat those other symptoms like anxiety and depression. And clinicians, therapists, we should all know how to treat those things. And so it's really helping folks just understand really more around those communications and understanding that autism and intellectual disability perspective and how that fits in with anxiety, depression, that kind of stuff. So I think it's a little bit of a hesitation, therapist being a little nervous, I'm not going to be able to help this person, as well as mental health right now in our society. I think that stigma's going away a little bit or lessening. And so more and more kids, teenagers, young adults are seeking services. So there's just in general a big push for a need for more, psychological services. Emily, did you have anything else you wanted to add?
No, I appreciate both you and Andrea hopping in on that one. It is close to 1, so if you do have to hop off, you're welcome to, and you'll get credit. But if there's any last questions, we're happy to take any additional questions.
And while they're taking questions, I will go ahead and share the, so there's their contact information, and then I'm gonna go ahead and, as soon as I can get my technology to work, going to share, first our schedule. Let me do it quickly over here. Oh, sorry, now you're seeing all my stuff is popping up. Here are upcoming webinars, and then here is our QR code to complete our evaluation survey. It helps us to know what we could do better, so if you could please do that, we would appreciate it. Someone will also paste that in the chat, or I'll just do it right here. All right. Any other follow-up questions? Thank
Christy
you.
Osborne, I saw in the chat, asked if they missed the first part of the presentation, if there will be a recording, and I believe this will be posted on YouTube, correct?
Yep, and Manisha will be sending that out to everyone once we got it edited and set up for recording. And just to plug, next month, we're going to talk about sexual health and sexual and relationships, and talk really about that sexual education for individuals with intellectual and developmental disabilities. So if you're not registered for that, please join us, and thank you all for being here.
It looks like Janae has her hand raised.
It might have been that we didn't lower it from before.
Janae, if you do have another question, you're welcome to ask it at this point.
Can you all hear me?
Yep.
Okay, can you email me the survey so I can take it? Because I haven't quite figured out as a screen reader user how to get stuff like that out of the chat. I can see it, but I can't access it. Don't know how to click into that.
Janae, we can have someone email that to you.
Okay, thank you.
No problem. It looks like we have one other question. How do we register for more trainings? You registered for more trainings the same way you registered for this one. Is that accurate?
Yep, and Manisha, can you paste the registration link into the chat for our participants that are still on? And maybe in the follow-up email, you can give them the link to register for more registration.
Of course. I will open the registration back up as soon as we end this webinar. Currently it is closed, but it will be open promptly at 2, but I can definitely share the link.
Thank you. All right, well, thanks everyone. We will talk to you later.